morning, everyone. We now move into our next session, When Care Breaks Down, Lessons from the Frontline. A session that asks us to pause and look closely at the moments we'd rather look away from. In healthcare, it's often not the big failures, but the small, missed signals that quietly build up to harm. To steer this important conversation, we have with us two respected moderators, Dr. Parivalavan Rajavelu, Consultant Surgeon at Sundaram Medical Foundation, Chennai, and founder of SkillsForMED Training Centre LLP. Dr. Kumar S, Senior Consultant and Head of Department, Cardiac Anesthesiology, Meenakshi Superspeciality Hospital, Madurai. We begin with our keynote address titled, The Anatomy of Failure in Healthcare, Small Gaps, Big Harm. I invite Dr. David Bates, Chief, Division of General Medicine at Brigham and Women's Hospital, USA, and ISQua Academy Member to deliver the keynote. I'll just get
Thank you. I'll be talking about failure in healthcare. All right, so I'm going to start by talking about evidence about adverse events. I'm going to focus in particular on adverse drug events. Then I'll talk about the role of learning healthcare systems. Then I'll talk about measuring safety in the future. I want you to get a sense of how dangerous healthcare is compared to some other activities that we take on. So for areas like nuclear power, European railroads, and scheduled airlines, we have fewer than one death for 100,000 encountered. For healthcare, the only things that are as dangerous as healthcare are bungee jumping and mountain climbing, and those have more than one death per 1,000 encounters. And to put this another way, commercial airlines have gone many years between deaths. The estimated death rate related to healthcare in the U.S. alone is over 100,000 per year. What is an adverse event? Well, an adverse event is any undesirable or harmful outcome experienced by a patient as a result of medical care, and that includes treatment, medication, or procedures. So an example would be getting a rash related to penicillin. A preventable adverse event is an adverse event associated with an error. So the patient has a known penicillin allergy, but we give it to them anyway. Adverse events can be divided in terms of severity. Many are significant, like getting an infection after having an IV catheter placed, but many others are worse. For example, having orthopedic surgery resulting in a long-term disability, or getting too much medication after a procedure and needing to go to the ICU and be placed on a ventilator. We did a study that was published in the New England Journal just a couple of years ago that looked at the frequency of harm in hospitals in Massachusetts. And we studied a number of different hospitals that were representative of the state. And what we found was that the chances of being harmed by going into the hospital was about 1 in 4. It was 23.6%. The percentage of admissions that included at least one adverse event was higher among older than younger patients and among men than women. Adverse drug events were the single most frequent type of harm. Events related to surgical or other procedures were more likely to be rated as life-threatening. Healthcare-associated infections were most likely to be fatal. And patient care events were more likely to be preventable than other event types. So what does this mean? Well, there's more focus today on patient safety than when the Harvard Medical Practice study was done. That was the first study that introduced the problem of patient safety. We have better processes and documentation. But despite this and advances in some areas of prevention, patient harm appears more frequent. although among all admissions, the mortality rate was slightly lower. And we did use a broader definition of an adverse event, which resulted in identifying more harm. The results do identify the clinical areas that have the most harm events, but it's clear that improved ability to identify harm will help us do a better job in improving safety. In this study, we also looked at outpatient care, which had not been studied in the previous study. And we found that 7% of patients had at least one adverse event in the outpatient study in the course of the study period. Again, adverse drug events were the most common event. Overall, about a quarter of adverse events were preventable. Now, progress in safety has occurred in many areas. So we're doing better with preventing hospital-acquired infections, like bloodstream infections, ventilator-associated pneumonia, and catheter-associated UTIs. In the U.S. now, all medications are ordered using the computer so that they're checked for problems. We do require barcoding of medications. Both those things have been very helpful in improving safety. Many effective strategies for preventing blood clots are still available. So why are we still having so much harm? One general approach which can be really helpful for doing better, I believe, is implementing learning healthcare systems. What is a learning healthcare system? Well, it's a healthcare system in which internal data and experience are systematically integrated with evidence, with what we know. That knowledge is put into practice. A couple of examples of this. Vanderbilt has done this very effectively, and they compared normal saline with Ringer's lactate, which are two things that we were taught were about the same. It turned out that Ringer's lactate was used mostly by surgeons, normal saline by internal medicine. But a randomized trial showed that Ringer's lactate actually had a mortality benefit. So this is the opposite of what I would have said going in. They did another study looking at intubating patients in the emergency room, which can often be difficult. There are two approaches. You could either use a flexible laryngoscope versus a rigid laryngoscope. The flexible ones are more expensive. But it turns out that actually there was a big reduction in the mortality rate if you use the flexible one. At Mass General Brigham, we've developed a tool to identify important radiologic abnormalities and make sure that those get followed up. And we're now doing that across our whole system for every single patient. Okay, so what are some of the challenges and gaps in using electronic health records to find patients who've been harmed? These are listed here. There's a company in the U.S. that's using an approach which we're really excited about. Their company's name is Pascal Metrics, and they use data from the electronic record to find signals that suggest that a patient might be harmed. Those are reviewed remotely by the Pascal team. They then notify the Frontline organization. You can identify some of the events before the harm actually even occurs, or at a time, really upstream of that. And they have several different modules. So this is built on a platform which is integrated and is now used in a couple hundred hospitals in the U.S. And this enables you to develop dashboards which show you how you're doing. So the graph on the left is all-cause harm over time. I think most institutions would be very happy to see that. You can also do it by a specific type of adverse event, and that is shown on the right-hand side. We're planning to do a study across the state of Massachusetts, and the government of Massachusetts is going to pay for this. The governor has allocated funds in her budget to do it, and we will evaluate 6 to 8 hospitals. Our team will do the evaluation, and we'll look at the impact on the frequency of harm and the economic impact. The economic impact is probably biggest in our poorest patients, which are patients on Medicaid. And in general, that's a finding that you might expect to see. And the idea is that this would then spread. I think the future of adverse event detection is to do this using the electronic health record. And you can, again, detect events after they've happened, but more importantly, even before. You may want to contact either the safety team, the care team, or even patients themselves. We did a study in which we told patients what their risk was of having an adverse event, and they actually were very happy to have that information. So overall, I think it's clear from these data that safety needs to be improved both inside the hospital and outside it. Medications are the leading cause of harm in both settings. The learning healthcare system approach can help organizations improve and ensure that important improvements are spread. Safety should be measured in the future using data from the electronic health record. And finally, artificial intelligence will help with all of this. And ISQua can help point you in directions that will help you improve the safety of care that you deliver. I will stop there. Thank you.
Thank you, Professor David Bates, for that very illuminating
Thank you
talk.
very much,
Thank you so
Dr. Bates. Let's now move into what promises to be a very honest panel discussion. Everyone saw the problem, but why didn't anyone stop it? Joining us for this conversation are Dr. Srinivas Samavedam, immediate past Chancellor, President of ISCCM, Colonel Binu Sharma, Executive Director, Lone Star and CEO, INS India, Dr. Umar Ram, Director and Consultant, OBGYN, Sitapati Clinic and Hospital, Chennai, Dr. A.K. Ravi Kumar, President-elect, IMA Tamil Nadu and Director, Mauti Nursing Home Private Limited, Coimbatore, Dr. Shin Ushiro, Deputy Director and Divisional Director, Division of Patient Safety, Kyushu University Hospital, Japan. A diverse panel bringing perspectives from across disciplines, geographies, and lived experiences of care delivery. I now invite our moderators to please take the session forward. Thank you.
Thank you. Welcome all the speakers. And we have been given a strict thing that the session has to be shortened a bit. So, but at the same time, I think the value of this learned panel has to go to the audience. Before starting, I'll just set the tone of what we are experiencing in the Indian culture. So there has always been this thing about that everything happens for NABH, and after NABH, everything, all the things sort of dial back to the zero. And how do we bring this safety culture? So you're talking about learning culture. So how do we do that? And I think we have a major challenge in India because of the culture we have, which right from school, that we are punished for our mistakes. So not only do we not divulge our mistakes, we don't want to tell about others' mistakes because that person will be punished. I think this culture is very strong, and this is reinforced when they come to the workplace, where most of us, myself including as a culprit, when any mistake is made, we just start yelling at that particular person, and therefore they will stop reporting the incidents. So this is the culture we have mostly in most hospitals, and we're trying to see whether we can build in a learning culture in this sort of scenario. With that context, I want to now go to Dr. Samadevan. What do you think? Do you think hierarchy in critical care teams plays a role in whether junior staff or nurses speak up? And when they detect a problem, do you think that they have the independence to actually tell it out?
So, thank you for having me here for this meeting, and thank you for the question as well. Hierarchical systems are probably inevitable in an organized teamwork like critical care, anesthesiology, emergency medicine, and in those operative areas. But what the hierarchy actually can do is to encourage and foster a culture of empowerment to the people down the hierarchy, so that the newest or the youngest member of the team can actually highlight an error or a departure from accepted norms which the top people are actually doing. Simple example, if you ask ourselves how many of us have empowered our nurses from stopping the senior consultant from handling a patient if they have not washed their hands properly. If we ask that question and all of us can say, yes, I have empowered all my nurses, then we have established the correct hierarchy in our hospital. I think that's an example I can give.
Yeah, thank you, sir. Thank you for putting forth your nice thought in ICU setup. Very good evening to everyone. Thank you very much for all staying till the last session. Hope it will be a useful one. We'll move on to the next discussion. This is to Colonel Venu Sharma ma'am. You are with a vast experience in military service. Can strict military command structures sometimes delay illegal decision making during emergencies?
Sorry, what is your question?
No, that strict military command structures, military command structures, delay the clinical decision making during emergencies.
Okay, thank you for the question. I think it's such a valid question. Should we have a structure or framework for emergencies, or should we act impromptu? In planned care, a structure is at most important, where you've got defined clinical pathways for every disease management and everyone follows it. Hierarchy is also well defined. There it works wonderfully. But when it comes to emergencies, if you are going by hierarchy, we are going to lose lives because seconds matter there. A respiratory arrest, a cardiac arrest, a polytrauma, you are not going to wait for the command center to tell you what to do, how to do. Many times nurses, doctors, bedside staff knows what is the problem and what is to be done. Delays happen because they have not received the order back. They are anxious and scared to move forward, but there should be leadership and authority and absolute flexibility when it comes to handling emergencies, is my take on.
Thank you, ma'am.
Yeah, I think it's a very important point that we not have hierarchy, but I think still we need to have frameworks in which they can react to a particular emergency.
Empowerment is not taught in any curriculum of nurses and doctors. Communication is not taught to them. Rather, staff is told not to speak up, and that is where the care breaks down. And even though when somebody knows there might be a problem, they do not speak up and they do not point out. A nurse is scared. Lack of training, lack of knowledge, lack of confidence, lack of communication, lack of empowerment, and the punitive action will be taken on her when she speaks up, even at the right time, are some of the underlying problems.
So what do you think is the one thing you can do to change this?
See, in my opinion, empowerment cannot be blind. Nurses, junior doctors, first of all, they need to have the right knowledge and orientation when they join a hospital. They are both at the bedside. Both should have enough confidence, the knowledge, and they must also know clinical pathways. But they should be made sure that if they speak up for the right cause for patient safety, for patient advocacy, it is the right thing to do. Don't bother about your job. No one is going to take away your job. This confidence can only be given by the hospital leadership. So the CEO must spend some time at the nursing stations to see how the bedside staff is working, how they are empowered. Actually, empowerment is most inadequate at the bedside where it should be highest. Seconds matter there, minutes matter there.
So empowerment at the bedside, leadership, and I would add that the middle management plays a very important role in sort of implementing.
It is staff driven how empowerment has to be assigned.
Okay, we have to move to Dr. Kumar S. You're an obstetrician and gynecologist. So how much do you think communication gaps play a role, especially you have a complex interaction between the obstetricians, anesthesiologists and other labor nurses in your system? So what is the role of communication in errors in our system?
I think communication is the key. And I think there are two issues that can happen with communication. One is, of course, that when something is happening, and to reiterate what the first speaker said, we've had some situations where you have a junior doctor who's just come into the system. In the labor ward, there is a senior nurse who realizes that that CTG trace is not okay, but this doctor hasn't yet recognized that there is a problem. They don't speak up out of deference because they assume that the doctor, they cannot contradict the doctor. So this, we have to tell both people that, whoever identifies the problem, that just because you're a junior doctor doesn't make you better than a nurse who's interpreting a CTG. And if there is a doubt, anyone can speak up because time becomes critical in these situations. So communication, concerns about am I overstepping somebody in reaching my senior can be something that contributes to delays in identifying. The other is communication between the team when an emergency is going on. It could be in PPH, it could be in shoulder dystocia. Whoever's keeping the time becomes crucial, and usually that's a junior member who's assigned to that task, but their role is vital. So that is internal communication. Of course, communication in obstetrics becomes a challenge because often the partner or the caregiver is in the room when a problem is happening. So it is not like something happens in an ER or an ICU when there isn't a family member in. In many obstetric situations, the husband is in the room. So we have to communicate effectively without causing alarm. And that, because that's not the point to say, you please step out, something is going wrong. That's not going to go down very well. So I think that is a unique situation in obstetrics where the team has to understand why we are requesting something, and at the same time we explain that you are starting to bleed more, therefore we are going to ask for certain things to be done, and this is normal protocol. So that reassurance and communication without losing speed becomes very critical, and that can only happen with a very well-oiled team.
I think there are two important points to be. One is escalation communication. How do you do without the hierarchy coming into the picture, and also the team communication, especially in the presence of the family. So how far do you think we are in that journey?
I think we are recognizing the importance. I think most units recognize the importance, and but we still have a long way to go because this kind of communication is not taught to us in training. And I think the more we do it, the more mock drills we do, we get better at it.
Thank you, Dr. Kumar.
Thank you,
Dr. Kumar.
Thank you. With the availability of family members inside, it's very difficult in obstetric setup to communicate very transparently in many of the situations. But you well said about how
but
to handle
equally,
this.
when they see that we are responding appropriately, it actually can work in your favor. I mean, obviously they are perturbed, but we can, if we are talking to them and doing the right thing, many times when you then debrief, they say, yes, we realized something happened when this went wrong, and your team did everything they could at that time. So you can make it work in your favor.
Yeah. Thank you, ma'am. Thank you very much. We'll move on to the next question to Dr. Ravi Kumar sir. Sir is the vast experience and more into the IME. Along with that, he is running a nursing home out in nursing home. So in a smaller hospital setup where the personnel and resources are limited, how do you prevent early warning signs to be overlooked?
Thank you so much, sir. I bring greetings from Indian Medical Association to CAHO for a wonderful event today. And we represent majority of the smaller hospitals. As you said, the resource, manpower resources, economic resources, everything is under contained in the small hospitals. But the expectation of the patients and our duty is that we have to give the quality treatment to each and every patient who comes to us. I'll just give an example of which happened in my hospital itself. See, to start with, mine is a 40-bedded hospital. To start with, and now it is an accredited hospital, NABH accredited hospital. But to start with at the beginning, in the hospital, the oxygen system, initially we used to have cylinders. And we had a protocol that I fixed 2 to 3 persons in each floor, that the cylinder must be checked daily. The keys and everything must be seen that it must be there. That was about 20 years ago. And one fine day what happened is, we took the cylinder to the patient, we took the key, opened, but there was no oxygen. Once there was no mask. Oxygen is there, there is no mask. This side of situation. Then I thought we should have a central oxygen system and a suction system, and each and every room and each and OP, ICU, everywhere, it must be connected with the central system. Then we had the central console and the central system was made. And there I had a red light signal. I kept one in the reception and one in the oxygen console area, and I had fixed the receptionist to see the red light. If the red light comes, you should warn the person who is supposed to open the central system immediately. So this was going on, and there again, each and every time my ICU people or from the theatre, they used to give a call and say that oxygen is not coming, please look into it. And these people will be searching for the person who is supposed to open the console. Then I thought, so fixing up the person, that may be worth for a bigger hospital. The person will be sitting there round the clock. In smaller hospitals, he will be multitasking. He would have gone for some other work. So what I thought was, I kept an alarm system. So this alarm will give the alarm once the cylinder the pressure comes down. So this alarm will go up, that will go up in all the floors, so that anybody can run into that system and open the system. So this worked out very well. And I trained each and every person. It is not the only one person to go and open. So right from every person, right from the watchman to the sisters to the receptionist, they should go and open the cylinder once the alarm gets there. So that went on well. That recently what happened is, so alarm rang up, suddenly one sister went in, she opened, suddenly the console got burnt up. Then we searched, what is the reason? Why? I did not blame the staff, because we should not blame them. And when we went into the root cause analysis of why the console got burned, there is no electricity there to get burned. The console is only oxygen driven. Then we found out that sudden release of the pressure from the cylinder, bulk cylinder, will cause burns, fire. And also some oil in the bulk cylinder connection that can cause this fire. This we could, when we went in for the root cause analysis, we found that the sister who opened that, she just opened very fast, immediately. so that from high pressure, the oxygen came out, got burned. The lesson we learned is this, the cylinder person or the console person who has given that system, he should have informed us, or we should have analyzed this, and now we have made it a protocol that, and we have trained everyone in this line, and that is the thing. So the message here is, smaller hospitals, all must be jack of all art. You cannot have masters for each and every one, and everybody must be able to attend to it immediately. So that is the lesson which we learned.
Yes, sir. Thank you, sir. Thank you very much. Well said about the practical problems. I think.
Thank you. I think we're going to Dr. Shin Hoshiro from Japan. Preparing for this panel, I learned a lot about the history of patient safety in your country, of how it went from, you had a lot of series of mortalities in the early 2000s, and then it became a sort of criminal investigations. Operating theatre was almost a place of criminal investigation. The police used to come into the hospitals. And then over the years, you evolved into a really proactive patient safety system. So we really want to know what India can learn from you went through.
Okay, thank you very much. First of all, thank you very much for having me. I am Shiro. I'm from Japanese University Medical Center as well as accreditation body in my country. I'm a board member of ISQua Academy. And I'd like to highlight and I'd like to focus on the criminal investigation and the litigation cases and how we addressing it in my country. And in early 2000, one obstetrician in my country was arrested by police because of massive bleeding and the maternal death. But our obstetrician was working alone. Only one obstetrician was in the hospital. And there was no big hospitals nearby. So one night, obstetrician performed a cesarean section because there is no big hospitals nearby. But he came across massive bleeding and he can't stop it. And unfortunately, the patient died. And he was arrested. But obstetricians and professors of obstetrics stood up for him. And finally, he was vindicated. And the police department, the head of the police department, finally admit the inadequate investigation. And after that, a preliminary investigation for medical practices is getting less often and less often. And the Japanese leading political party and my organization and the Ministry of Health jointly launched no-fault-based compensation system for brain damaged baby, because brain damaged baby is really risky and it often ignites lawsuit, and occasionally it was criminalized many years ago. And now we have been running a no-fault compensation system that provides money and that provides investigative report to families. And we successfully observed a rapid decline in the number of lawsuit cases. And similar issue is happening in England, in United Kingdom. So late this month, I'm invited by UK Parliament virtually to lecture our no-fault system to member of parliaments in UK Parliament. So thank you very much. That's my experience.
Thank you. I think that's a very important lesson to learn, that actually involve the patients, be transparent about what you're doing, and that changes the number of litigations. I think that's what you brought on, right?
Yes. Yeah. You are mentioning the engaged patient and family, right?
Okay.
Yes, we work together, all stakeholders, including patient and family.
Thank you so much for sharing that wisdom with us. You heard that clarion horn. I think it's the end of the panel discussion, but I just want to end with one question, all of you, because all of you are from different backgrounds, and please keep it to just one sentence for lack of time. Okay? So, if you could change one thing about the system you work in, one thing, just one, what will it be? Samadev.
Accepting that safety and culture is not an optional activity, and it is actually an initiative which will improve your acceptability of healthcare in the community. If you accept that, the safer you are, the more accepted you are in the community. If you understand that across the organizations, I think we will.
Understanding about patient safety across the organization.
Yes.
Thank you so much. Dr. Ushiro.
Yes, I would say candid communication with the society, because I have been conducting press conference on adverse event over the last 25 years.
Candid communication with the
Yes.
community. All right. Thank you. Sir.
Yeah, what I would say is in the smaller hospitals like we should have proper checklist, and you should allow anybody to just write it in the complaint register or inform the hierarchy, so that the immediate steps has to be taken immediately and without any blame.
SOP and report. All right. Thank you so much.
And
Dr. Umar.
Yeah, so I think maybe two things. One is definitely improving teamwork and team communication over individual instruction or individual importance within an organization. And the second is to also educate the patients on what they need to do in terms of contributing to safety. So not withholding information, understanding that sometimes things can go wrong. I think, and they can also flag if there is an error. So I think
So,
that becomes important.
Involving the patients. So I'll take only one.
All right.
Vidusham.
I will go on collaborative approach to handling clinical situations. So a teamwork approach, improve the culture of reporting even near miss apart from adverse incidents, don't hide it, and no punitive approach.
Okay, more transparency. Sir David Bates, I will ask a counterintuitive question to you. Counterintuitive question. What did you learn from the experts in India which you can take back to your country? One sentence.
One thing that I learned from this part,
Yeah.
I mean, there's so many, I can't pick.
Just pick one.
Yeah. I mean, there's tremendous interest in improving safety and quality here, and much more enthusiasm from people in general than there is in the U.S., I would say.
Okay. I think with that message, I think it's a positive message. We have a lot of enthusiasm in doing that. I think all of you have to give a big round of applause to this panel. Thank you so much to all of you for sharing this time. Thank you.
Yeah. Yeah, I quickly conclude this session. As we come to the closure of this session, the patient safety failure can occur due to hierarchy or communication failure or fear of blame or punishment. That is what is happening in India. The failures in healthcare can happen not because of one person did not care. They can happen someone not allowed to speak or act or stop the harm in time. That is what is happening here. Today's discussion definitely brings out challenges similar across the countries. At least after this session, let us commit to strengthen cultures where speak up is supported, reporting is encouraged, and learning is continuous. I repeat, speaking up is supported, reporting is encouraged, and learning is continuous. Let me conclude with the quote by Lucien Leaf: human error is inevitable, but harm is preventable. So on behalf of organizers, I thank the distinguished panelists and my co-chair Dr. Parivalavan Sir and the engaged audience for the meaningful discussion. I take this opportunity to sincerely thank Dr. Lalit Joseph ma'am and my good friend Dr. Malati for including me as part of this program. Thank you very much. Have a great day.
Thank you very much for that very insightful and honest panel discussion. And I have a photo.
And while the photo session is on, can I request that we have Zubir Lasir Hygiene India for the product launch please.